I'm a nurse by background, so a big shout out for all the wonderful nurses in the audience. And, and I still work part-time for the NHS. I'm very pleased to be here this afternoon to talk about Antibiotic Research UK, and as the title of the presentation suggests, I'll spend a bit of time trying to focus on some of the really valuable work that we are doing to shine a light on the people behind some of the AMR statistics. You know we've only got about 30 minutes. Some of these slides are quite text heavy. So in the interest of time, I'll probably need to skip across some points as we go. And given the time constraints, I'd ask if you've got any questions, obviously, to try leave them to the end, and I'll do my best to try and answer them. Okay, I'm just going to give you a little bit of direction in terms of what we're going to talk about. So, I know you're all quite familiar, especially after some of the talks today, with the issues in terms of the threat posed by AMR, how complex and multidimensional it is, and why there is a need for really urgent action. So I will just touch upon this and then consider why this action really needs to focus on AMR as an inequality issue. We all know that the NHS is facing unprecedented problems. We hear it all the time. We live it, work in it, in terms of capacity, and that sadly this pressure can have a knock-on effect in terms of our ability to deliver continuity of care or to address unmet patient need around things like AMR. And so I'm going to discuss why Antibiotic Research UK is uniquely positioned to help fill some of those gaps in provision and talk about some of the work that we're doing to support the people who are living with drug-resistant infections. We'll then listen as one of those individuals tells her story, and then I'll end by discussing one of the initiatives that we've launched to help tackle some of those issues being highlighted today. So, this slide is a bit busy, but as you'll see, the take-home message is that AMR is a very serious problem. We talked about that lots today. It's a leading cause of death worldwide. But while the O'Neill report did forecast dire health, social, and macroeconomic consequences by 2050, if appropriate action is not taken, at the same time, the discovery of new antibiotic treatments is still moving at a relative snail's pace. For example, a recent study by somebody called Mika found that only about 1% of the agents in development at that time had reached the clinical trial phase, and only a tiny proportion of those had a novel mechanism of action, and none were active against, the horror of horrors, the horrible gram-negative escape pathogens that we worry about so much. And I'm sure many of you know, but escape acronym describes that group of highly virulent and often multi-drug resistant pathogens, bacterial pathogens that include things like Staphylococcus aureus, Klebsiella pneumoniae, and Pseudomonas aeruginosa. And these pathogens are a particular problem in hospital environments, and several of them have been included on the WHO list of critical threat pathogens. However, I should also acknowledge that, as Prof. Sally Davis has done, that the Global Antibiotic Research and Development Partnership is helping to bring new treatments to market. There was a gram-negative one that zoliflozin, if I can say it properly, that came onto the market, I think is approaching the stage 3 clinical trial phase. And likewise, the UK's new subscription payment model is providing additional incentives in this area. But not that anyone needs any further convincing after all of the talks we've heard about today, but this clearly highlights how failure to tackle AMR is just not an option. And in thinking about action, I think I was reminded of a statement that I read on the BSAC website. It was I think it was published in 2021, and it was from an expert in infectious diseases. His name is Mark Mendelsohn. And he discussed how infection prevention relating to antibiotic resistance is too often narrowly focused on control of the spread of infection in healthcare settings. And evidence suggests that more effort, if you look at some of the studies, is also needed to address antibiotic misuse as a major driver for AMR. Particularly as studies have also indicated that education awareness raising haven't always had the desired effect that we'd like in terms of driving long-term behaviour change that is needed to conserve our remaining antibiotics. And in fact, the WHO have listed the need for effective behaviour change interventions as among one of the top 40 research priority areas on AMR to be addressed by 2030. And that was when it published its global research agenda in June last year. Mendelssohn also argued that inequality lies at the heart of antibiotic resistance and, quote, "No one is safe until we are all safe." He went on to discuss how meaningful action requires that we move closer to the heart of stewardship by addressing the basic inequity across social structures. And this means we must consider how the wider determinants of health are influencing the development and spread of AMR. And I'm sure you've all heard this, that the clustering of factors driving both health inequalities, higher rates of antibiotic prescribing, and their use and misuse within, we'll just take the higher income countries here as an example, such as the UK, it is widely discussed in the literature, and it has been discussed today. And some commentators are therefore pushing for more research into the factors that are driving the development of the so-called prescribing hotspots that are described within the UK, the geographical variation in prescribing. For example, do they reflect increased health needs in those areas? Very probably. And if you take into account that the majority of antibiotic prescribing takes place in primary care, are there issues at play here regarding access, quality, or type of health service provision in these areas that we need to think about? Moreover, how are these issues connected, and how do we mitigate any of the negative impact from them? Rather interestingly, I thought, I read a recent scoping review, and they examined the influence of inequalities again in high-income countries. And it postulated that health system barriers could be driving people from vulnerable migrant communities to rely on alternative routes for antibiotic supply outside the traditional prescription supply mechanisms where barriers exist to accessing healthcare. And that's obviously very concerning. It also recommended that AMS initiatives should be more mindful of NHS England and NHS Improvement's Core 20+5 approach when designing these programmes. The Core 20 Plus, for those who may not know, represents people from most deprived 20% of the population. The plus is those individuals with protective characteristics or from ethnic minority groups. And then there are 5 clinical areas, including chronic respiratory disease. Okay, so just to highlight this again another way, if I can get the right slide. Yeah, that's it. Okay. This is some information I extracted from the 2022 to 23 SBAR report, and it demonstrates how AMI is disproportionately affecting people according to things like age, ethnicity, socio-economic categories, etc. They've only started collecting some of this data, I've noticed. So I think some of the categories are quite new from what I can gather. And you'll see that the proportion of antibiotic-resistant bloodstream infections detected among Asian and British Asian ethnic groups was almost double that reported for white ethnic groups for that year. And you'll also see that the burden of bloodstream infections was highest in the most deprived quintiles compared to the least. Of course, this form of inequity in terms of disease exposure and outcomes is something that we've witnessed before during the recent COVID pandemic. And as we know, this disproportionately affected those who are already disadvantaged and with devastating consequences. But ultimately, I think a quote that I read from somebody called Harani in 2021 summarises really succinctly why AMR needs to be reframed as a social issue. And that is because it is influenced by intersecting socio-cultural factors which not only drive its emergence and spread, but that also create barriers to tackling it. Anyway, so we've briefly touched upon some of the issues to be addressed, but I guess then what? Well, it would seem that because AMR is a social issue, we can't really expect to address it until we have a better understanding of the realities of those people who are most vulnerable to it or living with the negative consequence of these infections. Instead, we should be paying more attention to the people behind the AMR statistics. And this sort of people-centred approach has already been adopted by the WHO, and to use their own words, aims to put people and their needs at the centre of the AMR response. It emphasises the importance of working with people, be they patients, healthcare workers, academics, to name but a few, to explore barriers and drivers, thoughts, opinions and experiences of AMR, and then encouraging them to co-create some of the solutions. It works on the premise that unless we try to understand how AMR and the interventions designed to address it actually affect people, then we run the risk that those interventions won't address what really matters, and we risk perpetuating some of the gaps and inequities relating to AMR that I've just discussed. And Harani also said that, I think this is a real killer phrase, she argued that advancing public engagement on this issue is vital because long-lasting policy change really largely hinges on citizens actively demanding action from their leaders. So we need the public to be on board with us. Thankfully, Antibiotic Research UK has a really good track record of effectiveness in using patient stories to put a human face to AMR. We share these stories with media, NHS policymakers, industry, research, and it's to help ensure that decision makers actually do pay attention to the voices and realities of people affected by these infections. Antibiotic Research UK was established in 2014, and so yes, we are fast approaching our 10th birthday. And we were established to help tackle the global threat of drug-resistant infections. I use drug-resistant, antibiotic resistance, and AMR interchangeably, forgive me. We are the first and only charity in the world working to combat AMR through a combination of research, patient support, and education. The Patient Support Service was established in 2019 out of recognition of the need for better patient information, support and advocacy for those suffering from those resistant bacterial infections in the here and now. The service aims to bridge some of the gaps in the continuity of care offered to patients by supporting them to develop self-management skills and to negotiate often complex treatments and health services. Among other things, we also act as a source of high quality and reliable information about AMR and infection prevention to the public and healthcare professionals alike. So what do the people who contact us say, you may ask? Well, they often tell us how over-reliance on poor microbiological testing methods can mean that their actual symptoms are less likely to be taken seriously by healthcare professionals and even family and friends. And this is often because the result has come back wrongly, quote unquote, as negative. Many, therefore, when encountering that situation, seek to highlight their experiences of being treated with the wrong antibiotic, not being given, or it's not being given for the right duration, and/or at the right dose. And this is particularly the case for people experiencing urinary tract infections. And they often talk about how problems with the initial management has gone on to unleash a cycle of recurrent or chronic resistant infections that they are now left to try and live with. Such experiences have driven some patients to research and access private treatment, including bacteriophage treatment from abroad. And as you can imagine, where this is an option, it still comes at quite a great personal cost to them. So again, what this tells us is that ongoing drug-resistant infections are not only driven by inequalities, but they also reinforce them. Many sufferers are left unable to look after themselves, their home and children, unable to contribute financially to the household, and they often experience a significant reduction in their overall quality of life. But please, do not just take my word for it. I will try to introduce you to one of those people behind the statistics. And this is someone who's very generously agreed to share their words with you today. This is a lady called Caroline, and this is her story.
And so began weeks and weeks to and fro, backwards and forwards to the GP. I was really getting desperate. I managed to persuade them to give me 3 days of this, 5 days of that. But by the August of 2016, I said, look, I just want to go and see a urologist. I don't know what's going on here. So I saw the urologist in the August, and he took one look at my test results, and he said, you don't have an infection. You don't have had an infection since March. I suggest you seek psychiatric help. So I'm afraid I ignored that advice, and I did my own research, and I found a clinic in Harley Street that dealt with nothing but chronic UTIs. I went there in November 2016. They looked at my urine under a microscope, and they said to me, you've got a, quote, raging infection, unquote. And they put me on their regime of long-term, high-dose antibiotics. Well, unfortunately, I'm quite sensitive to medication. Suffice it to say that after 6 years and 11 different oral antibiotics, the side effects were getting so scary that I thought I need to come off everything, because I really thought I might have some permanent damage. So since then I've tried Chinese herbs, I've tried the Uromone vaccine, I've had gentamicin instills directly into my bladder, I've even tried phage therapy from home, but nothing has cleared this infection. I still have it 8 years on. I'm under no illusion that if the diagnostic testing had been accurate at the very beginning, and if I'd been given more than 3 days worth of antibiotics, I don't think this infection would have become chronic.
Okay, we'll stop there because it is quite a long talk, but I just wanted to give you a flavour of... but you can go onto our website if you want to listen to the whole thing. Okay. So from what I hope you heard there was quite a powerful account from Caroline, and as you've heard, she's still living with this infection some 8 years after she was first diagnosed. Many of the issues discussed in this piece by Caroline were also picked up in a recent phenomenological analysis by Hamilton and colleagues in an article published in Nature Scientific Reports. And this study was conducted with the support of Antibiotic Research UK, and it's one of the first in the UK to examine the lived experience of people with antibiotic-resistant infections. The study highlighted many of the same gaps in support that Caroline discusses, and that is how lack of knowledge, information and support is on offer from clinicians. And identified, we think very importantly, how that charities and online groups act as a crucial source of support to these patients, particularly when it comes to their mental health and well-being, which after a while inevitably can deteriorate. So we discussed how the WHO is using a people-centred approach, but how can you be sure when you're carrying out your research projects and developing that you are carrying out the right research and developing the right products and pathways that patients need and actually will bring about improvements in outcomes? Well, I think you can start by approaching the AMR Patient Community Advisory Board, or PCAB, and this vitally important initiative was launched by Antibiotic Research UK in 2024, so just this year, still relatively new out of the box. Our PCAB offers a route for groups of patient advocates and expert patient carers to come together and use their professional and/or personal knowledge and expertise to discuss and advise on the latest developments, challenges, and issues related to medical treatments and procedures under development in their disease area. It is being operated and run as a consultancy service to a wide group of AMR stakeholders, and Antibiotic Research UK will act to ensure that all of those PCAB members are supported to provide their expert advice and insight in a neutral, objective and we hope critically constructive manner. We strongly believe that the PCAB will help to fill some of the key knowledge gaps that exist among academia, research, industry, healthcare professionals, particularly when this comes to patient need, be that around quality of life, research priorities, experience of different treatments, diagnostics and aftercare. And this is necessary because, as previously discussed, AMR is a multifaceted topic covering a wide range of disease areas and conditions, and currently there is very little patient representation in that sector. In addition, the literature suggests that because these PCABs can help researchers to focus on the issues that matter most to patients and carers, their research is more likely to be relevant, the process likely to be more transparent, and in theory, implementation in practice will be faster. I've shared our contact details at the end of this last slide, the end of the presentation, and so please, I would encourage you to get in contact with us if you'd like to find out more about this project. I know we're very pressed for time, and you've been very patient listening to me, but I just want to quickly highlight another important priority area that we are looking to address, and this involves us working more collaboratively with groups such as yourselves. The Patient Support Service is looking at ways to make our work more relevant and accessible for all, and to ensure that we are addressing health inequality, that addressing health inequalities is embedded in our approach, especially because we acknowledge that we are only reaching a tiny proportion of the people who really need us. So we really want to be able to collaborate with healthcare professionals and your patients. It's a shared process. No one person is going to tackle AMR by themselves, but we do feel that we have an important role to play. So please do spread the word. An example of the work that we are planning to do is we are looking to collaborate with NHS homeless healthcare professionals to ensure that local AMR policies are more responsive to the needs of those who are more susceptible to antibiotic resistance. We're also in the middle of a medical writing project, and we're hoping that this will make our online resources more accessible to a wider audience, be they of patients or healthcare workers, to name but a few. And we are always looking to add to the diverse group of patients and lay reviewers and expert reviewers who work with us to give feedback on our literature. So again, please get in contact. And finally, we have relaunched our online peer support group, and I'm really pleased to report that this is flourishing. It is flourishing both as a safe space for individuals and caregivers to connect and share their lived experiences of living with antibiotic-resistant infections, but it also as a platform from which members can start to take collective action on the issues that matter most to them about this issue. So, I realise I have run out of time, and there is so much more I would like to have talked about, and that is particularly in relation to the research priority setting initiative that we've launched. But I think you probably all need a break right now. So I just want to summarise by saying that AMR, as we know, poses a significant threat to health, care systems, and human health, both within the UK and worldwide. It's multifaceted, it's global, and it is a social issue, and it must be addressed as such. While lack of capacity within the NHS is a major barrier to taking meaningful action against AMR at the local level, again, I would emphasise that Antibiotic Research UK is uniquely positioned to offer the continuity of care, some continuity of care and accessible and reliable information that people living with antibiotic-resistant infections so often need. And I think the launch of our AMR PCAB reflects our ambition to bring a more people-centred approach to future research and development efforts. So I thank you very much for listening.